A 6-day-old newborn was admitted with erythematous lesion over phase of 2 days duration. There was no history of administration of any drugs after birth. The lesion started behind the ear and spread to other parts of face, neck within the next 2 days. On examination at admission, the child was toxic, febrile with erythematous lesion around mouth, nose, and over the neck. The oral mucosa was normal. The lesion spread to the hands, gluteal regions, thigh, and legs over the next 2 days. The skin easily comes off with gentle pressure. The child responded to injection vancomycin with no new lesions and became pyraxic within 48 hours, which is the most likely cause for this condition. IgE-mediated hypersensitivity, cell-mediated hypersensitivity, endotoxin-induced inflammation, exotoxin-related damage, and skin invasion by microorganisms. Let's look at the case with more detail. So the case given here gives us that it is a 6-day-old newborn with erythematous lesion on face. There is no history of drugs taking after the birth. The child is toxic. The mucosa is normal. The lesion has spread to other parts of the body, and now skin easily comes off with gentle pressure, and treatment with vancomycin has worked. So the answer is exotoxin mediated damage. Why? Because it is a case of staphylococcal scarlet skin syndrome. So Nikolsky's sign, it is a clinical dermatological sign named after Pyotr Nikolsky, a Russian physician. It is dislodgement of intact superficial epidermis by a shearing force, indicating a plane of cleavage present in the skin. The sign is present when slight rubbing of skin results in exfoliation of outermost layer of the skin. Whenever this sign is positive, we can at least look at 3 possibilities: toxic epidermal necrolysis, pemphigus vulgaris, and staphylococcal scarlet skin syndrome. Now, SSSS and TEN, that is toxic epidermal necrolysis, are our topmost 2 differential diagnoses here. But because there is no mucosal involvement in our case, it is most probably staphylococcal scarlet skin syndrome. The other differences are skin biopsy would show intraepidermal separation in case of SSS, while it will show subepidermal separation in case of TEN. The prognosis is excellent in SSS with complete resolution in 10 days in case of children, but the prognosis is variable and dependent on multiple factors in case of adults, while in case of TEN, the prognosis is overall poor. The other differentials of staphylococcal scarlet skin syndrome are the Lyle syndrome, or what we know as TEN. Second, epidermolysis bullosa, bullosa mastocytosis, herpetic lesions, and neonatal pemphigus. The staphylococcal scarlet skin syndrome is also known as pemphigus neonatorum or Ritter's disease or localized bullous impetigo. The syndrome is caused by epidermolytic exotoxin, or otherwise known as exfoliative toxin A and B, which are released by Staphylococcus aureus. This toxin causes detachment within the epidermal layer of skin by breaking down the desmosome. Actually, this toxin acts as a protease that cleaves the desmolagen 1. The desmolagen 1 normally holds the granulosome and spinosome layers together. The disease here present with widespread formation of fluid-filled blisters that are thin-walled and easily ruptured, and then patient can be positive for Nikolsky sign. The disease is very common in children under 6 years, mainly infants and young children. The lack of protective antibody to this toxin and immature renal function, which impairs the ability to excrete this toxin in urine, have been suggested as the common reason for that. It can also be seen in adults who are either immunocompromised or have renal failure. In neonate, the staphylococcal skin disease can present as any of these 3 presentations: staphylococcal scarlet skin syndrome, bullous impetigo, or staphylococcal scarlet fever. The SSS and bullous impetigo have many features in common. That's why they are difficult to distinguish. But with help of these few points, we can distinguish them Clinically, skin lesions are usually larger in case of SSS, while in bullous impetigo they are smaller. The culture from the skin lesions usually don't isolate Staphylococcus aureus, while the isolation rates are higher in case of bullous impetigo. The inflammatory infiltrate in skin is less compared to bullous impetigo in case of SSS. The Ritter's disease of newborn is the most severe form of staphylococcal scalded skin syndrome with similar signs and symptoms. The SSS often includes a wide spread of painful erythroderma, often involving face, diaper, and other intertriginous areas. But extensive areas of discommission might be present. The perioral crusting and fissurings are also seen in early course. In infants and young children, potentially fatal complications include like hypothermia, dehydration, and secondary infections which can lead to pneumonia. The diagnosis of SSS is made clinically. This is sometimes confirmed by Staphylococcus aureus from blood, mucous membrane, or skin lesions. However, these are often negative. The mainstay of treatment for this condition is basically eradication of primary infection, along with the conservative measures like rehydration, antibiotics in form of NSAIDs and paracetamol, management of thermal burns, and stabilization. The antibiotic of choice here are vancomycin, oxacillin, or ampicillin because most of these Staphylococcus aureus have penicillinase. Clindamycin can also be considered because its role in inhibition of exotoxin. Thank you.